Good morning. We're going to call this meeting to order. We're going to start off with the NVAC chair giving his welcome remarks. Dr. Bob Hopkins, please take it away.
Well, good morning, and thank you for joining us for today's NVAC meeting. I want to thank you, Ann, for getting us started, and to the NVAC team for its work in planning this meeting and supporting the committee throughout the year. I also want to thank the NVAC members and subcommittee members for their dedication to furthering the work of this committee. I look forward to the presentations and discussions today. I want to begin with a few housekeeping items. Then I would like to briefly review my takeaways from our first day, and we can move on to a high-level overview of today's agenda. In terms of housekeeping, I want to make sure everyone is aware that this is a public meeting, and it's being webcasted on the HHS website. We will once again have sign language interpreters available on the HHS live stream. I appreciate the efforts of this team to make our meeting more inclusive. We ask that everyone speak slowly and clearly to assist them in supporting our meeting. For our virtual participants, please remember to mute yourself when not speaking, and please don't use your camera unless you're presenting, asking questions, or answering a question. During discussion, I ask that all members and speakers, virtual and in person, identify themselves before speaking if I don't acknowledge you by name and giving you the floor. This helps the note taker and others to follow along. Throughout the day, there will be opportunities for committee discussion. If you'd like to ask a question or provide a comment, please send me a message through the chat feature if you're online. As always, members of the public can provide a public comment by phone at 2:15 p.m. today. Public comments are not a question and answer session. They represent an opportunity for an individual who would like to make a statement to do so. The deadline to request a space for public comment during this meeting is passed. However, anyone can submit a written comment up to 3 pages in length at length to NVAC@HHS.gov. I'd like to spend a few minutes briefly summarizing my takeaways from day one. Dr. Levine kicked us off with her welcome and acknowledgement of Pride Month and charged the committee to develop a set of priorities and actionable data elements for the 2025 iteration of the Vaccines National Strategy to be voted on at our February 2025 meeting. We heard from a panel focused on proactive planning to facilitate effective and rapid response to emerging diseases such as avian influenza, including maintaining viral seed stock, antigens, adjuvants, ongoing research, and assuring nimble production capabilities so we can rapidly get vaccine to the highest risk individuals and then to the public at large for the next declared pandemic. Our second panel focused on assuring equitable availability and engagement with LGBTQIA communities, especially persons of color, for Mpox vaccinations as we move closer to Mpox vaccine commercialization. Take-home messages to me were partnerships, 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 and reinforcing the message that scarcity is the enemy of equity in assuring vaccine access. Our presentations on lessons learned in planning for the 2024-25 fall and winter respiratory disease season emphasize the need to continue to work collaboratively across the immunization neighborhood to assure vaccine access, and that uptake will depend on clear, transparent, and open communication with updated data, and we need to engage our trusted messengers. The brief update on the outbreak of measles in Illinois reinforced the challenges in defeating an outbreak in the setting of a large migrant influx and a downward trend in MMR vaccination rates. And our final panel on cancer vaccine innovations provided us with a brief foundation on the challenges and opportunities for cancer vaccines to prevent recurrence, to treat cancer, and to prevent and interrupt cancers. Success in the cancer vaccine space will require breaking down silos, investment, and continued innovation. All right, I got myself out of order a bit here, folks. I apologize. So for highlights for today, we will open today's session with a panel on innovation and improvements in immunization data. Following a short break, we'll hear an update on global immunization efforts and how vaccines have saved over 150 more million lives worldwide. We'll then hear about research on switching arms between COVID-19 vaccine doses. Just before lunch, we'll hear updates from our federal agency and liaison members. And after lunch, we will hear from our colleagues in the U.S. Department of Health and Human Services about their work toward an updated national vaccine strategy. Our day will conclude with public comments. Finally, as a reminder, please hold our remaining 2024 meeting dates for your calendar. That's September 12th and 13th, 2024. And please refer to the NVAC website for final details on upcoming meetings. At this time, let's turn to our first panel. Our first panel is entitled Immunization Data, Innovations, Improvements, and Updates. And I'd like to invite our presenters to the stage while I introduce the panel. This is an important panel as immunization data helps us to meet our goals for routine vaccination across the lifespan and in public health emergencies, where targeted data can help make better decisions. Innovations, improvements, and updates help patients, providers, policymakers, and health agencies in a myriad of ways, including identifying areas of inadequate vaccine uptake, improving outbreak responses, predicting trends, and more. Our presenters are Dr. Jason Asher from the Centers for Disease Control and Prevention, Dr. Shannon Stokely from the Centers for Disease Control and Prevention, Rebecca Coyle from the American Immunization Registry Association, Dr. Pamela Belperio from the Department of Veterans Affairs, Dr. Patricia Lloyd from the U.S. Food and Drug Administration. Dr. Asher, you have the floor.
Well, thank you very much. I'm really pleased to be here on behalf of CDC's newest center, the Center for Forecasting and Outbreak Analytics, to share some of the work that we've been doing that I think will be of interest to the committee. So CFA, as I said, is CDC's newest center. We were formally established at the beginning of last year, and we're here because we envision a world in which people and public health decision makers are empowered to save lives and protect their communities from health threats by harnessing cutting-edge analytics to improve our responses to public health emergencies. And CFA is here to do that across three main functional areas that we call Predict, Inform, and Innovate that represent our three divisions. And they all come together to create our larger goal of creating a world-class forecasting and outbreak analytics organization. I'm here as the director of the Predict division in our center, and Predict is the analytical heart. We are building a large data science team within CDC that's focusing on delivering actionable analysis during outbreak emergencies and pre-positioning response-ready modeling tools so that when the largest challenges face our nation, we have the tools that we need to bring forecasting and other modeling capabilities to bear. Predict does its work closely in concert with two other divisions, Inform, which is here to help with science translation and communication, a really important component of this. As I think we all recognize, we live in a world in which modeling results can become front page news. And when that happens, we need to make sure that the models are appropriately contextualized, that the questions they were intended to answer are clear, that the assumptions and limitations of the models are clear as well, and so that people understand how future information could change the impact and the assumptions behind the model. Innovate is here to provide two main functions. One is our extramural research. So this is where we try to work on better data or better analytical tools to invest in the future, as well as providing some wraparound support services on the technology side, including software development and data integration. This past year, our center, together with the National Center for Immunization and Respiratory Diseases, worked together to publish the first Outbreak Outlook. This product was intended to give public health decision makers advance notice of what they could expect in terms of peak burden in the hospital across influenza, RSV, and COVID-19. We did this by combining expert judgment as well as some modeling results, and we used this to outline possible scenarios for the fall. When we did this, what we found was that peak burden for this past year, from the combination of expert judgment and modeling was anticipated to be larger than what we had seen even in the most severe respiratory seasons prior to COVID-19, but not as high as what we had witnessed during the Omicron wave of the pandemic. Our outlook projections were accurate in the sense that what was observed was in the range of the scenarios that were described. And this is a product we're going to continue to refine in the future, including this fall, where we're going to introduce some dimensions that relate to vaccine uptake. Another product that we launched this fall with our same colleagues in the Immunization and Respiratory Division was a state level estimate of the degree to which COVID-19 and influenza were growing, remaining the same, or decreasing in terms of transmission. These are public facing RT estimates that while the data are available for download on our CFA website, they provide at a glance a quick indicator of what is happening with transmission, as well as providing some quantitative measures of how intense transmission is. This past spring, they were initially launched with focusing on hospital admissions data. We pivoted that to focus on reports through the emergency department that come into CDC as the admissions data was no longer available. And this was actually the first signal of the increases in COVID-19 transmission that we were witnessing initially in the West that have expanded to other states in recent memory. And so this combined two key capabilities. One was our ability to now cast a signal to account for incomplete reports. So when you look at the raw signal, you would have seen continued declines in emergency department visits, but in fact, they were increasing, but it would take us weeks to be aware of that. And then some additional quantitative work to figure out how to actually estimate the rate of transmission. So we're excited about this as a capability that we'll be able to maintain throughout the summer and into the fall, monitoring COVID-19 transmission rates at the state level. There's a long history of forecasting at CDC. In particular, our flu division for more than a decade has been collecting ensemble forecasts of multiple outside partners to bring them together to think about to provide a quantitative measure of what is happening with hospital admissions with flu. This year was the first time that our center, bringing a new capability to the agency, contributed models that were generated by modelers and analysts within the agency. It established the first time that we were doing this, but also that we had this capability in-house that we're going to continue to refine in the future. We've also started producing forecasts for COVID-19, and we'll continue to resume that in future years. On the COVID-19 side, we have been interested in trying to think about how we can use new data sources to improve our ability to forecast. Starting last year, we worked with the division that manages the National Wastewater Surveillance System and looked at how wastewater data could help us improve the quality of our forecasts. Wastewater data can be collected and processed and tested in a shorter time frame from the point of infection because people start shedding virus in their feces earlier than we would ever detect them in a clinical setting. And so by pairing this data together with our forecasting models, we were able to show that at key points in time, when it's the most challenging to make a forecast, when things are about to change, but we haven't witnessed it in any of our surveillance signals yet, that wastewater data can help improve the quality of forecasts. We then turned that initial pilot into a forecast model for COVID-19, which we had been publishing since about February of this year. And we're going to extend this to other pathogens as well as that kind of data becomes available. We see this as a promising development for improving forecasting. I also wanted to offer, I heard that on agenda yesterday had some people coming to talk about the measles response in Illinois and Chicago. Our center integrated closely with the CDC response for measles, and this was one place where we were able to provide real-time forecasting and outbreak analytics in direct support for our partners in Chicago and in Illinois. What was key here was that we were able to do two things. One was to provide actual forecasts of what was anticipated for future cases that might emerge through the shelter. And those forecasts became more accurate as data became available. The other thing we were able to do was quantify the benefit of the rapid vaccination campaign that occurred in the shelter and in the surrounding area, showing that there was in absence of that campaign and in the absence of active case finding, there would have been a much larger outbreak with high probability. We think this is another important point to make continuously because responses to measles outbreaks are incredibly expensive. And this represents a way that we can use modeling tools in real time to help communicate that and understand the benefit of the actions that we're taking. And then finally, wanted to share some results from our Clade 1 Mpox response. So as many of you may remember, in 2022, there was a large outbreak of Clade 2 Mpox transmission in the United States among men who have sex with men. In DRC at the moment, Clade 1 has been spreading in a number of different regions of the country. And the concern here is that at least in household settings, Clade 1 Mpox may be more transmissible than Clade 2. So the question that we were exploring with our modeling tools was what hypothetically could happen if Clade 1 Mpox was introduced into the United States. And we pursued two avenues here as part of the response. One was thinking about household transmission, and our transmission modeling results suggested that the household transmission risk of Clade 1 Mpox was limited in the United States. We did some agent-based modeling for sexual network transmission of Clade 1 Mpox, hypothesizing what might happen if it was introduced into that setting. And what we found was that for some communities that had relatively high immunity from a combination either of previous infection or vaccination, there was protection against large outbreaks. But for others that had lower rates of vaccination in particular or accumulated immunity, there could be a risk of larger outbreaks if clade 1 mpox were introduced. And we were able to use this as part of the response to meet with specific jurisdictions and talk through the importance of continued vaccination for mpox. So that's all I was coming here to talk about, but I'm looking forward to the discussion later. Thank you.
Thank you. Our next presenter is Dr. Shannon Stokely from CDC. Dr. Stokely, your slides are up. You have the floor.
Thank you and good morning. I'm sorry I couldn't be there in person today, but I'm Shannon Stokely. I'm the Deputy Director for Science Implementation with the Immunization Services Division. Next slide. And so in our division, we are responsible for monitoring vaccination coverage. And we know that vaccination coverage is really important, to understanding where there may be gaps, which populations may be missed, and where we should be focusing our efforts. And we do this through numerous data systems, partly because there's no one single data source that meets all of our needs. So we take advantage of multiple data systems that are available to us to help understand the vaccination coverage landscape and then help direct program activities. Next slide. So just listed here are some of the systems that we use, and some of these may be familiar to you from the pandemic, but also through the fall respiratory season. And we have data, vaccine administration data, we have survey data, we have claims, electronic health record data, and also vaccine ordering data. And we use all of this information to help us understand what's happening. Next slide. So one thing I wanted to point out today is what our plans are for the fall respiratory season. We have the respiratory virus data channel that posts a lot of our surveillance metrics for the fall season. And these are updated on a weekly basis. And I provided the link below at the bottom of the slide. Next slide. So for vaccination coverage specifically, we do post each week vaccination coverage for children and adults. This just shows the graph for children. And for this posting, we rely on the National Immunization Survey for these for estimates, because when this is a nationally representative survey and system, we get weekly estimates. And we can do this for multiple populations, for children, adults. And then we also have information on socio-demographic characteristics, as well as attitudes and beliefs about vaccination. And so come this fall, when the season begins, we will be updating this site weekly, and I provided the link down at the bottom. Next slide. And this just shows the slide, the graph that we have for adult vaccination coverage. Next slide. And then I also wanted to highlight our respiratory vax views. You may be familiar with our other dashboards that we have for children, for teens and adults. We also have vaccine-specific dashboards for COVID, flu, and RSV. And on these dashboards, we provide much more information than what I just showed, which is a very high-level summary of vaccination coverage. This provides information for different populations by socio-demographic status, and also different data sources. So not just our National Immunization Survey, but also data from immunization information systems, IQVIA or claims data, and also some CMS information as well. So I encourage all of you to visit these sites throughout the season. And again, they'll be updated weekly or depending on the data source. Some sources may update monthly. So next slide. So now I just want to spend a few minutes talking about our vision for immunization information systems. I know throughout the pandemic, people learned more about these systems, and they became an incredibly valuable resource for helping us monitor vaccination uptake and coverage. So next slide. And so our vision has evolved over time as systems have matured. We still provide resources, technical assistance, and monitoring of IIS functionality, but we're increasing our focus on the data contained within these systems and use it to drive public health action. And it's important that IIS data be of high quality and in a form that enables data linkage to paint a full picture of public health. Next slide. And just a reminder, IIS data are population-based and provide important information on vaccination coverage and help us identify areas of low coverage, as well as characteristics of populations with lower or high vaccination coverage. And there's important work going on to look at the quality of IIS data and improve the completeness of the information included. Next slide. Now, I know many people, when we think of IIS, we think of the technical infrastructure needed to support the systems and think about more technical issues. But I just want to highlight that the policy landscape is also very important to the IIS functioning, and that IIS are governed by state level policies. And these policies vary across the country. And they vary in terms of who is included in the IIS, how the information is reported to the IIS, and also how that data is shared with CDC and other partners. Next slide, please. So I just want to highlight the three focus areas for our priorities. One is technology infrastructure. So IIS need to meet defined standards and have robust functionality that ensures that they can operate with electronic health records and to receive and send data. Of course, data quality is really important. We've defined data quality metrics in our IIS data quality blueprint. And this provides regular feedback to jurisdictions through our quality reports to drive improvement. And then data exchange. IIS must be interoperable to enable data sharing between the IIS and providers to receive data through our immunization gateway and provide data to the public through consumer applications. And this also includes privacy preserving record linkage, which is a tool that allows data linkage without sharing any identified information with CDC. Next slide. So just digging into the technology infrastructure, here are a few of the resources that are available to jurisdictions and partners. And first, we have our functional standards, which describe the required functionality needed for the IIS to support programs, providers, and other partners. And these standards are designed to drive consistency across the IIS. HL7 implementation guide provides the technical standards and best practices that IIS can use for interoperability. And then we have alignment with standards that can be measured through our work with ERA, which I see Rebecca's on the panel today, so you may hear more about this through the Measurement and Improvement Initiative. Next slide. So this leads to our second focus area, which is data quality. And so briefly, CDC historically did not receive IIS data from all jurisdictions. Prior to the pandemic, we received data from 13 jurisdictions through a special program that we had with the jurisdictions and through specialized funding. The data shared with CDC had strict limitations on use. But during the pandemic, we did receive data from all 64 jurisdictions. At first, they were reporting daily, but over the course of the pandemic, that changed to weekly and then monthly. Now we're building on that progress to establish reporting of routine immunization data to CDC. We currently have 54 jurisdictions reporting record level de-identified data on all routine immunizations, and they report this quarterly. And we also receive monthly aggregate reports for specific vaccines. And you can see from the table at the bottom that most of the 54 jurisdictions are reporting regularly. Next slide. And so the IIS data quality blueprint defines a small set of meaningful quantifiable measures for IIS across 4 different data quality characteristics such as availability, completeness, timeliness, and validity. And this blueprint also includes recommended activities for data quality characteristics, as well as other additional characteristics such as accuracy, consistency, and uniqueness. Next slide. And so CDC is working on multiple ways of providing feedback to jurisdictions on the quality of the data that they share with us. We provide validation reports that give immediate feedback on the files that they submit. And then we're working on routine vaccination data quality reports that will show trends over time in areas that may need improvement. And then lastly, for those jurisdictions using privacy preserving record linkage, we provide a report of potential duplications and patient IDs with missing required values. And these are all important tools to help improve data quality. Next slide. And so our final area of focus is data exchange. And the Immunization Gateway is a message routing system that facilitates data exchange. And this can be done between jurisdictions, so from one IIS to another, also through multi-state providers, so like federal agencies such as the VA, and can submit data to jurisdiction IIS. And we also have IIS to consumers, so those are through other applications, and IIS can submit data to CDC. So in addition to directly facilitating data exchange, participation in the IZ Gateway streamlines policies such as data use agreements. Next slide. And currently, with respect to our IZ Gateway data exchange metrics, we have 63 jurisdictions that have completed baseline onboarding, and 36 jurisdictions representing 205 connections are exchanging data with one another. 7 providers representing over 4,200 facilities are exchanging data with 42 jurisdictions. We have 1 consumer access application, and then 20 jurisdictions are sharing data with CDC. So this represents significant progress in data completeness at the jurisdiction level, while simplifying the process for providers that have presence in multiple jurisdictions. Next slide. And then one last project I wanted to mention that we're undertaking is to improve standardization, is the local implementation guide digitization project. When local implementation guides are not standardized, it can cause delays with onboarding, increased difficulty in leveraging the IZ Gateway, and difficulty with sharing data. This project uses the National Institute of Standards and Technology HL7 implementation guide, authoring a management tool to digitize each jurisdiction's implementation guide to make it more accessible and usable. And through this project, we're also standardizing local guides to ensure each one follows national standards and complies with the latest HL7 conformance and methodology. Next slide. Last but not least, I just want to mention, in order to make all of this happen, it's important that we have resources available to continue the progress we've made and to build on that. So next slide. Within the FY 2025 President's budget, the request does include a request of an additional $50 million above the FY 23 appropriated level. And if this is approved, some of this funding can be used to help support the modernization of IIS and help make them even better. So we're looking forward to results of what happens with this budget request. But we know IIS are really important to supporting immunization programs. So I'll stop there and look forward to the discussion. Thank you.
Thank you very much. Our next presenter is Rebecca Coyle from the American Immunization Registry Association.
Well, thank you, everyone. And it's a perfect segue from Shannon's presentation. I think she went a little in covering a lot of what IIS does. So I'm the executive director at the American Immunization Registry Association, and we're a member association that works with all the jurisdictions and CDC to really advance immunization information systems or immunization registries. So I want to talk about the promise of modernization. And for those of you that are maybe less familiar with immunization information systems, they've been around for 30 years in a lot of places, even longer. So we're really talking about a very deep history and a lot of data in a lot of these systems, depending upon how long they've been in existence. I also want to just talk about the synergy with the public health modernization efforts or the data modernization initiative. And just very briefly, I am not CDC, I'm not with ONC, but just to sort of paint the picture of sort of what's happening outside of immunizations and how that relates to IIS. So there's currently public health modernization efforts going on. It is coordinated between CDC and also the Office of the National Coordinator for Health IT. And I just want to note that the initial focus has really been on a lot of the surveillance systems out there. So that includes case reporting, labs, emergency department visits, and vital statistics data. You'll notice that immunization data doesn't traditionally show up in the very first round. And so that's been a little bit of a challenge to try and get our mission to the forefront, that IIS are really part of the modernization efforts. What Shannon was just talking about with having functional standards and HL7 guides, I know that sounds like, what is that? It sounds very mythical, but these don't exist for all of the other public health data systems. And that really does help advance immunization information systems in a very standardized way. And that's ultimately what all of public health wants to do. IIS just happened to be a little bit ahead of that. You can see on your screen, and again, these are just sort of the overall vision for public health data. I won't spend much time on this, but overall is to really strengthen public health data across the board. I think this panel is an excellent representation of where that's coming from and how that is being strengthened. For IIS, I want to talk about sort of the pursuit of modernization and what that looks like on the IIS front. So over the last 5 years, there's been a lot of attention on IIS in a way that was never necessarily anticipated, but really brought to light a lot of the work that's been done over many years in a way that I think was very positive. So during the response, from the minute the first vaccine went in, it was automatically being transmitted to the IIS. So we had very real-time information in a way that has not been, it just hasn't happened before. And then for the first time, at the federal level, there was an ability to see that as well. So there are a couple of things that were put in place to enable that. One of which is that there was a requirement, a federal requirement for providers to report that vaccine to the immunization information system. So Shannon mentioned that policies are incredibly important. I can't understate how important those really are, because that's ultimately what drives data and where it goes. We also saw a lot of onboarding of new providers to the IIS, which was fantastic. But we also saw sort of some capacities reached over time. If you think back to April of 2021, some of the systems were just so overwhelmed with the amount of data that it crashed a couple. And so some had to go to limiting like what could be transmitted during certain times. One of the promises, though, was moving to cloud hosting, which really allows for that scalability, particularly in emergency, being able to scale up or back down. I will say that while this allows flexibility and the ability to scale, it is not necessarily more cost effective or cheaper. So I think that is a huge issue that a lot of programs are running into now, is that their costs have doubled and quadrupled over the last several years. As Shannon mentioned, the Measurement and Improvement Initiative, this was really launched almost 10 years ago. And the reason for this was meaningful use came about in the early 2010 through 2013 era. And there was a lot of attention on how varied IIS were across the US, and a desire for IIS to operate in a very seamless fashion. And so we looked collectively across the community and said, what can we help do to standardize our community so that we truly are able to say that we are operating from the same set of standards and we're doing the same thing where we can outside of policy. And so the Measurement Improvement Initiative was launched. It's a rigorous set of measures that are established by the community. They are very the bar is set pretty high, meaning that we really want IIS to be achieving what they say they can. So this includes everything from data quality to clinical decision support, as well as the onboarding components. It is not all encompassing in that it's a certification type system, but there are certain programmatic areas where we are at the point where we can say concretely, this is how each IIS function in this area. And I also want to say for the first time, we have all of the jurisdictions participating. This is a voluntary program, so I think it really speaks volumes to, we want to provide not just a measure to the external world, but also concrete information that IISs can use internally to improve their systems. And so providing that value back is important to us, and I think to the jurisdictions as well. Some of the promises I think out there, so thinking about HL7, which is the messaging standard or how things are transmitted between systems. There's also, we've been using V2 for many, many years. It's been very successful, but there's also newer messaging standards out there like FHIR. And I think from our perspective, we don't really want to think about it as a rip and replace all of the standardization that's been in place under V2. What we really want to do is look at where it can augment the weaknesses or where we don't have great functionality right now. So thinking about querying for lots of records or bulk query, as we like to call it, this is a potential use for FHIR standardization. Another area where I think we have our eye but don't have any funding right now is thinking about how vaccine inventories are managed and how that information is shared back and forth. It's a little clunky right now when it comes to decrementing vaccines from inventory. So there's a possibility that FHIR might be able to augment that and make it more efficient and effective. And as Shannon just showed you, the IZ Gateway is working. I almost want to get up here and do a dance, but I don't dance. This is so exciting. For the last 10 years, we've really been talking about trying to exchange data across jurisdictions and with federal entities. So this is really happening. It's very exciting. We're all super thrilled about this. And then I think sort of stepping back, as I noted in the very beginning, some of our systems are 30 plus years old, and we're at the point where we really need to think about how they're structured and how they can be structured more efficiently. Some of that technology is very old and very spaghetti coded together. So thinking about it from a modular perspective, what do each IIS need to be able to do? And I think this is where there's a nice intersection between IIS and then some of the data modernization initiatives, which I'll talk about here in just a minute. Of course, I can't really talk about modernization efforts without also talking about some of the fiscal needs here. So there was a lot of money that was placed at jurisdictions' feet to really work to get systems up to speed during the pandemic, and IIS were absolutely a beneficiary of that. However, next year on June 30th, all of those funds are set to expire. So we are really facing a point in time where jurisdictions are questioning what resources they're going to have available. What can they actually maintain and sustain over time? Thinking about just the system capabilities doesn't factor in the workforce that's also needed to support these systems. And as things have grown and capabilities have been added on to over the last couple of years, we're really talking about unwinding and stopping a lot of these features and functions that a lot of the US has come to rely on, and providers in particular rely on. So knowing what is ahead is really very murky, and I can't stress that this is, we will see an impact from reduced funding. So I said I'd come back to some of the opportunities because it's always fun to talk about funding and be like, yeah, this is great. So let's talk about where there might be some opportunities. So thinking about the vision of IIS and where we want to be in 10 years and 15 years, I think there are really some key strategic discussions that need to happen so that we can define very concretely, what does it mean to be modern and what does it mean to do that in a uniform way. We need to identify the goals across the board for all of IIS. And then we need to very concretely say, this is what every IIS should be able to do and by when. We also need to talk about how these systems are going to be updated, who's going to be funding these. The federal government funds in large part a lot of these systems. There are some state dollars that go in there, but there's not a lot of private dollars out there that have gone to these systems, even though we know that they have a broad benefit for everyone in the country. And then I think lastly is defining what does success actually mean? So really defining those measures and ensuring that we achieve those as well. As Shannon stated, policies are so critical to the modernization efforts. They really provide value for all. So some of the policies that have now been sunset are providers required to report COVID vaccines. I think there's really a need to require providers to report all vaccines. That is how you will know what your patients and your population look like and what resources they might need, where you can strategize and put your efforts into vaccine campaigns or really honestly trying to prevent the next outbreak of certain diseases. I think it's also important to say that providers need the ability to look up immunization histories from the system they're using. Going out of different systems and logging into others is clunky, it's not efficient, and it's really hard to do that in a very quick visit. So making sure that that bi-directional capability, being able to query, respond, and have all of that right in front of you is essential. Consumers or individuals need to have access to their records. It is so important that individuals know what is in their vaccination history so that they can also make decisions along with their provider about what vaccines they need and take control of their health. I also think just being able to use data we found during the pandemic, and I think we knew this ahead of time, but really saw it very acutely during the pandemic, is that IISs cannot be used for research in a majority of jurisdictions. That is just sort of a foundational policy that has been implemented for many decades. So thinking about how IIS data can be used, I think there's a need to be able to use aggregate data. If you think about the information that we have and mapping that to vaccines that are out there, we could really look at vaccine efficacy data in a new way, but a lot of this is very limited by the policies that are in place today. So rethinking how we can use that data and for what purposes. Some of the strong core functions, so thinking about the data modernization initiatives across all of public health. If you think about sort of a one front door approach to public health, and if every provider is coming to public health, they don't want to have to connect to case reporting or labs or anything else. They want to be able to do that in a seamless way. So some of the ways that I think I hope will prove to be very beneficial across public health is if you think about some of the common features and functions of systems. So one, there's a need to match people. It doesn't matter what system you're in, patient matching is a huge piece. Is there a way to leverage that across all of public health for the individual purposes? Thinking about deduplication, there's always going to be duplicates. There's going to be duplicates of patients. There's going to be duplicates of vaccines. There's going to be duplicates of all sorts. So can we do this in an efficient way that really benefits all of public health? Some of the dashboards that have been highlighted by the prior presenters, I think are really important. The US population has come to rely on these dashboards, but how can we do that seamlessly and efficiently? They are time consuming. We don't always have all of the great methodology behind the scene to make this happen. Sometimes it's really just several people putting spreadsheets together and then putting that on a website. But there's definitely a more efficient way to do that, and how we can do that across public health is, I think, a promise. And then I noted onboarding. So immunization information systems, we have about 140,000 independent connections between IIS and providers today. That's 140,000 independent connections. That's huge. But thinking about that from sort of a systems perspective, and if all of those providers then have to do that for all of the other public health use cases, is there a way for us to streamline onboarding to where you can onboard one time and be able to connect to all of the different systems? I think is another promise as well. So I think there's a lot of conversations that need to happen about these specific topics and really identify concretely where we want to go. But these are some promises I think are worth noting and looking into. And then just lastly, I think, as Shannon noted, some of the funding for next year is really unknown. I really think the strategies for funding IIS have got to be considered. It really, truly should be a public-private partnership. There is a role that everyone plays in making these systems efficient and effective. And I can't stress enough that if we really want IIS and we want public health in the next emergency, we have to fund it today. It is incredibly challenging to throw just gobs of money at a problem in an emergency. there is not the capacity that at the state or jurisdiction level to have the individuals and the workforce on hand to be able to execute everything that needs to happen in an emergency and be able to do it efficiently and effectively. And if we don't make that investment today and continue to make that investment, public health will not be available in the next emergency. And I know that sounds very doom and gloom, but I really can't stress this enough. We have been through enough epidemics. We've been through enough pandemics to see this time and time again. And I think we need to really put a line in the sand and say, it's time to stop. It's time to rethink this. So with that, I will say thank you, and I appreciate the time and look forward to the conversation.
Thank you, Rebecca. Our next presenter is Dr. Pamela Belperio from the Department of Veterans Affairs.
Thank you.
Your slides are up. You have the floor.
All right, I appreciate it. Sorry, I'm on the West Coast. It's a little dark over here, but thanks for having me, and I'm looking forward to providing an update and overview of our collaboration with the CDC for the VHA IZ Gateway. Next slide, please. So for those of you that don't know, the VA is the largest integrated healthcare system in the United States. Each year, we see over 6.2 million veterans within one of our 1,321 VA medical centers or facilities or outpatient clinics each year. And about a third of those veterans receive some type of care in the community as well. We currently have 2 electronic health records. One of them is our Vista legacy system, and we are in the process of transitioning over to our Oracle Health system, for which we have about 6 VA facilities that are on that new electronic health platform. Next slide. So we have been trying at the VA to exchange immunization data with the states for years. However, we have been limited by multiple barriers that have really prevented us from being able to do so in an efficient way. And the most the most challenging aspect truly has been the state requirements and laws that don't align with our federal and legal and privacy requirements. And as a federal entity, we are subject to federal law, which takes precedence over state law. So therefore, before we can sign many of these state agreements, they have to be modified to meet our federal legal and privacy requirements, which is a legal battle, as you might imagine, and can take multiple months to even years to get those changes in place before we're able to sign those agreements. The second major barrier that we have had is that federal law actually prohibits us from disclosing veteran immunization information to state and public health authorities without unless it's explicitly mandated by the state law, and we have a standing written request letter from the state indicating that. And then we would have to have a signed authorization from every veteran before we can transmit or share that information with the state public health departments. Next slide. So that's why our collaboration with the CDC and the IZ Gateway has really been a game changer for us, because with this development, we now have the opportunity for a national automated solution for the VA enterprise-wide, because it avoids multiple individual point-to-point connections with each of the jurisdictions and states. So we don't have to have, 54 or 62 different connections to each individual state. We have one singular connection to the IZ Gateway. And it also standardizes that policy and infrastructure so that we don't have to have 54 different multiple individual agreements with each of the states and jurisdictions in order to exchange that information. The other benefit is that because the IZ Gateway is maintained and managed by the CDC, the federal law does allow us to disclose immunization data to other federal entities. And so it allows us an opportunity to not have that requirement to get that written veteran authorization before we disclose this information through the IZ Gateway. And so again, now we have this single point of connection. Each of our 1,000 VA facilities we're able to pull immunization information, or that information gets pushed into a centralized VA hub that is then, we have the single connection to the IZ gateway, which then, of course, as Shannon explained, routes that information to the individual IISs and where that individual VA facility is originally located. Next slide. So on the back end, we maintain a centralized infrastructure. It's fully automated. And as I mentioned, each of our electronic health medical records, and for each of our VA facilities, that information is pulled into this middleware platform where we do a custom transformation into the HL7 messaging, and then we have that single point of connection from the middleware program to the IZ gateway. It results in a seamless integration such that even when we receive that information from a response back from a query, that middleware program again transforms that information into readable format so that the immunization information is imported directly into our electronic medical record. So this is an unattended process. There's no provider review that happens when we do a query. We have a very sophisticated algorithm on the back end that matches patients, deduplicates any existing immunization information before it's added into the RVA electronic medical record. Next slide. So again, these are the four main functionalities of our immunization exchange. We are reporting all VA administered vaccinations at the time that that vaccine encounter is documented in our electronic medical record. It happens in near real time. We're querying state and jurisdictional IISs using a pre-fetch process. So between 1 and 3 a.m. every morning, we are sending out queries for patients that have appointments the following day. And that information then is imported and ingested back into our electronic medical record so that it's available for providers at the time that they're going to see that patient. And the box on the right-hand side, you can see in red, it's very clear to providers which immunizations were received from the immunization gateway. It's identified specifically with IZG, the two-letter state abbreviation, and the IIS from which that information originated. We also have a couple of back-end capabilities. We have an error handling dashboard that's used by our team that tracks every single immunization that we send out through the IZ gateway and every query and response that we receive from the IZ gateway. We have the ability to filter that by state. We can look at any error messages that are associated with any immunization so that we can track any responses or any questions or errors that we receive in regards to our processing. We also have an accounting of disclosure dashboard in case a veteran does want a record of any information that we sent outside of VA to other entities. Next slide. So I love, a good before and after picture. Really proud of the work that we have done in collaboration with our CDC and IZ Gateway colleagues. We started the development of this project in September or October of 2021. By June of 2022, we were reporting to our first jurisdiction, New York City. By August, we were reporting to the 7 states that you see in blue there. And actually by January of 2024, we were bidirectionally, so query and reporting to 45 jurisdictions and states across the United States. And by June, we are reporting now bidirectionally with 47 different states and jurisdictions. So in an 18-month time period, we made significant progress thanks to the collaborations with the CDC and the state IISs. Next slide. And so just to give you, quantify the value of this project, again, it serves not only our veterans and providers, but also external providers as well. We have reported over 6.2 million vaccinations that our veterans have received. Over 4.1 million veterans have received over this time period. That information has been shared through the IZ Gateway with the corresponding state IISs. And we have received over 12.8 million vaccinations from our communities through the IISs for over 2.2 million veterans since we went live with querying back in July of 2023. We do have a few outstanding states, those shown with the red boxes, that indicate that those states have not yet signed the IZ Gateway Agreement, so we're unable to share information, immunization information with those states currently until they sign those agreements. Next slide. And again, this just shows you the volume of immunization data that is being exchanged with the VA through the IZ Gateway. The values in red are immunizations that we import each month through query, and the values in blue represent the immunizations that we report out from the VA to the state IISs by month. And you can see that peak during our peak influenza campaign through September through November, when the most immunizations are being administered through the VA because of that diligent campaign within the VA system. Next slide. So again, there's a couple of states that still have not yet signed the required IZ Gateway Agreement for us to begin that data exchange with them. Alabama, Hawaii, and Pennsylvania. We do work closely with our CDC colleagues, and they have IIS liaisons that have been really diligent in trying to help us move this forward. For each of those 3 states, the agreement is with their legal teams, but we've been told that they have other priorities that have pushed this to the side for the time being until they can prioritize the signature for the IZ Gateway Agreement. New Hampshire and South Carolina have told us that they have state laws that prevent them from signing the IZ Gateway Agreement. And so we will pursue an independent agreement with them, although that will be a timely process, but we do intend to do that. But again, there's over 500,000 veterans that are in these 5 states that currently are not receiving the same, consistency of care that other veterans from other that live in other states that are connected to the IZ Gateway are experiencing. And it also obviously presents a risk for duplicate immunizations, as well as challenges in tracking and targeting outreach interventions. And so if the committee has any recommendations for helping us to engage and prioritize with those states, we would be most welcome to those recommendations. Next slide. So again, because of the sheer volume and the breadth that the VA has undertaken in terms of immunization data exchange, it gives us a really unique perspective. And Rebecca and Shannon had talked a little bit about data standardization, and we can see that there clearly is, while there's a lot of standardization through the National Implementation and Immunization Guides, there seems to be a need for standardization, particularly in response messages, ACT messages, the way that errors are handled within the states. Again, we see the breadth of variance across the different states and how they handle things. And so we've documented and have shared that information with our colleagues so that, again, that might be used as a starting point for where we have identified areas where standardization and improvement could be used to help with other multi-jurisdictional provider onboarding. Next slide. And so again, we're really proud of the collaboration and the advancements that have been realized through the IZ Gateway. Again, it has expanded our interoperability primarily. We're thrilled with the public health collaboration that this has resulted in, and of course the expanded immunization information for all end users, whether that's internally within the VHA, for all of our veterans, and externally for the IISs and the community providers that utilize those IIS systems. So thank you very much. Appreciate the opportunity to present to you all today.
Thank you, Dr. Balperio. Our final presenter in this panel is Dr. Patricia Lloyd from the U.S. Food and Drug Administration. Dr. Lloyd, I see you on the video and your slides are up. You have the floor.
Excellent. Thank you so much. Good morning, everyone. Again, my name is Patricia Lloyd, and I'm a health statistician with the Office of Biostatistics and Pharmacovigilance and the Center for Biologics Evaluation and Research at the U.S. Food and Drug Administration. Next slide. So here's an outline of the presentation. I'm going to talk a little bit about the CBER Active Surveillance Program and talk about the IIS, Immunization Information Systems Claims Data Linkage, and talk about the regulatory and public health impact as well as conclusions. Thank you. So the FDA Active Surveillance System that proactively monitors the safety and effectiveness of biologics, including COVID-19 vaccines, is the FDA Biologics Effectiveness, Safety, or BEST system. And the Active Surveillance Program conducts surveillance of biologics through multiple interdisciplinary partnerships, as illustrated here. So for safety surveillance of COVID-19 vaccines, for instance, that monitors potential rare adverse events, we collaborate with federal partners, and we work with large nationwide health plans, as shown here. So I just want to give or share how many groups we work with, how many jurisdictions we work with. And I'll show in the next slide, I'll provide kind of how this is done. But overall, you can see in green and dark green are the jurisdictions where our data partners, all three of our data partners, commercial health plans, have been able to link claims data to these various IIS. And in lighter green, this is where at least 2 data partners, and in the lightest green, we have at least 1 data partner that's linked to these jurisdictions. And then in red are those jurisdictions that are not currently sharing. I think as was brought up previously, there are a lot of different policies since this is a state. These are managed by the states. Not everyone has the same capabilities to share and policies to enable sharing with the FDA. But I will share a little bit later how useful these data are in monitoring the safety as well as effectiveness of these vaccines or of vaccines. Next slide. So this slide just is a very high level overview of our partnership with the IIS. And so when we started this process a couple of years ago, we reached out to all IIS, informing them of the work that we were doing to look at the safety of COVID-19 vaccines. And I will mention the reason why it was so important for us to work with IIS is, as you know, particularly for COVID-19 vaccines, while a lot of the vaccines were reported by providers in the claims databases, there were many more vaccinations that were administered outside of that system through mass vaccination campaigns. And so a lot of the exposure information or vaccine information was actually not collected in the claims databases. And this really, as we were looking at the safety of the vaccine and later effectiveness, we wanted to ensure that we had the most accurate accounting of the vaccines and who was receiving the COVID-19 vaccine. So we, again, reached out to all of the various IIS across the country. And we, with our data partners, shared essentially the plan for linking data, which is that the IIS work individually with our data partners. They have data use agreements that are managed between the data partners and the IIS. And they link the claims databases, where the claims databases have information about various health outcomes that we're monitoring with the data partners. So IIS provide data and link data to claims databases, provide that back to the data partners. The data partners clean, validate, aggregate, and analyze the linked vaccination and claims data per FDA protocols. So we have a single protocol that all of the data partners follow, that summarizes and provides the standardization for how our studies will be performed. And then this dotted line just tries to indicate that there is this firewall. What FDA receives is really just the aggregate data. So the data partners provide the aggregate summary data to FDA to monitor vaccine safety and effectiveness. So FDA does not receive any individual level data, but rather the aggregate data from our data partners. Next slide. And this table, I know it's a little bit busy, so I just want to highlight, this came from a feasibility study that was done with one of our data partners at the time of, so when we first began doing the linkages. So this was in the study period was December 2020 through December 2021. And this particular data partner linked to about 11 states. And we looked at the amount of information that were provided from the claims alone, and then from the combined IIS claims data for receiving at least one dose, and then also receiving the complete primary series of the COVID-19 vaccine. And you can see in that first row, this is looking across all of the states, that when we were able to use the linked claims, IIS claims data, we were able to improve the number of single doses that were observed in our database from 32 or 33% to about 48%. And then if we looked at the complete primary series, when we looked at claims alone and then using the linked IIS claims data, we went from 24% to almost, well, about 42%. So you can see there's quite a jump in the amount of information, amount of data that we have on individuals receiving the COVID-19 complete primary series. And this is incredibly useful to our efforts in monitoring the safety and effectiveness of this vaccine. Having complete exposure information is going to give us a more accurate understanding of the safety of the vaccine. And next slide, please. Thank you. So I just want to share the regulatory and public health impact that these data had on our work. So BEST studies have contributed to the emergency use authorization and approvals during numerous FDA advisory panels. We also have been able to work with our group who performs benefit risk assessments, who presented data on the benefit risk of COVID-19 vaccines, which informed regulatory decision-making. And then as part of both passive and active U.S. surveillance system, the BEST studies contribute to the advisory committees that determine the public health policies regarding vaccines in the U.S. Next slide. So the IIS really are crucial in FDA's safety assessment and surveillance. We were able to use the data that came from the IIS claims or a linked IIS claims database to really define the risk of myocarditis pericarditis after mRNA vaccines in young males. We're also using the IIS data could provide more power to detect these potential rare safety outcomes after vaccine receipt. And these are really crucial to our vaccine effectiveness studies. So in measuring how effective this vaccine or the COVID-19 vaccines were to adults over 65 years and over, as well as to our pediatric populations, the IIS data were crucial, were critical, again, providing more exposure information than we would have had if we used only claims data alone. Also, IIS data were essential to look at the exposure of JYNNEOS and ACAM 2000 and looking at mpox prevention. And so again, and I've only focused here on mostly COVID-19 and mpox, but we're using this for influenza as well as for RSV. Next slide. So in conclusion, the BEST initiative contributes to FDA CBER's mission to ensure biological products are safe and effective. We do this through active surveillance. And IIS data really complement the COVID-19 claims data and adds up to 50% more immunization information for timely evidence-based regulatory decision-making. And again, I'm really thinking of all the vaccines that we are looking at in our surveillance studies. IIS Mpox data captured 9 times as many vaccine administration as the claims data alone. And so continued and expanded IIS data linkage is needed for BEST to continue generating rapid and comprehensive response to the COVID-19 pandemic, to Mpox, seasonal influenza, and also other future outbreaks that require vaccine administration. Next slide. So I just want to acknowledge here our team and our data partners, and thank you very much for your time.
Thank you, Dr. Lloyd. Are there any questions from the members of the committee, either online or here in the room? Steve?
Hey, thank you so much. I learned so much at every talk here. I have a question, probably for Shannon and Rebecca. Rebecca, you mentioned that it's so important for providers to really have that history. When they have the patient in the office, they need to know what vaccines that patient has already had. And also mentioned that the IZ Gateway is up and working and functioning and provides a data exchange between IISs in the different jurisdictions. My EHR provides a data exchange with our state IIS, but I don't get dates from out of my state as far as vaccines that have been received. Is that happening, or should I expect that, or where might the hitch be?
Will you remind me which state you're with?
Iowa?
Iowa. So I'd probably have to look into that a little more closely to see like where that might be. But I do think you sort of highlight a unique challenge in that there are multiple places where things have to be checked to make sure that it's flowing seamlessly. So I'm happy to follow up with you after that. Shannon, I don't know if you have more that you could add to that.
Yeah, I don't know the specifics in that, so I'd have to check and get back to you with as well.
And I can check with our immunization manager too. Thank you. It should work though. Okay.
Molly Howell.
Thank you. This is probably for Rebecca. I know looking at secure funding for IIS, you were talking about private partnerships, but one other way some states have been successful is through Medicaid match dollars. And I'm wondering, this committee might be interested in understanding if there are certain barriers to states accessing Medicaid match dollars, and can you think of any potential workarounds or things that this committee could recommend or suggest to make it a little bit easier for states to access Medicaid match dollars to support the IIS?
It's a great question. I actually think Shannon could be helpful with this response as well. So I think Medicaid has notoriously been challenging for some jurisdictions to assess or to be able to access funding through. I think one of the unique challenges that you have to have some state contribution to access most Medicaid funding. So we know that less than 50% of states have state funding that likely can be put towards any sort of Medicaid match. We think that this is a real challenge. I think from the federal level, I know we've talked a little bit, and I think Shannon and her team are also working with CMS to see if there isn't a better way to establish some sort of data sharing agreements and then also funding across the board. We know that Medicaid patients make up a large portion of individuals within an IIS, but maybe they're not contributing in the same way. So having that conversation, I think, is really important. I appreciate the suggestion, Molly, because I think this committee could really be beneficial in looking into this more.
We have a question from Hannah Al-Shali on the line. Hannah, go ahead. We'll not seeing her come through. Mitch, why don't you go ask your question and then we'll come back to her.
Okay, thanks, Bob. Great presentation. Question in regards to the gateway and facilitating the VA being able to share data. Is there any further discussion of how do we get Medicare data to populate like the VA is doing to try to get the information to be more rich that's being shared in the IIS? Has any more discussions happened at the federal level of how do we engage the Medicare data like the VA did for their data?
So we have had conversations with CMS regarding Medicare data. I think the important thing to remember is VA is an actual healthcare provider. So they are providing services and they have their own electronic health records, and I'll let Pam talk more about that. But whereas Medicare receives claims and they pay them, so it's a little bit different, but we have talked to them and we continue to have conversations to see what we can do to support each other, because we know our information can help them improve their claims to make sure they have complete information, because not all vaccines have a claim, right? So some adults may get vaccinated and a claim is not submitted because they're getting vaccinated through work or through some other resource. So Medicare may not have full visibility on vaccinations that are happening with the population they care for. And also some claims don't, those people getting vaccinated don't make it into the IIS. So there would be some benefits, and we continue to talk to see how we can work together to make that happen. But again, the state policies also play a role as well, because it's the state policy that does make sometimes sharing data more complicated, even between federal agencies.
And just a comment on the presentation from Jason earlier. I think some of our forecasting tools were very helpful this past respiratory season, looking at COVID, influenza, and RSV vaccine uptake. Are there any major changes planned in those reporting systems as we go into next year, or this year, I should say?
I think in terms of the kinds of technologies we're going to employ, we're trying to take some lessons we learned from last year to improve accuracy of some of our internal forecasts. There are changes to the data systems, as you may know, for hospital admissions data. That's still working its way through the policy process, but we are hopeful that if those data are available again, then we will resume the same kinds of ensembles we had last year, both with internal forecasts and external capabilities as well.
Thank you. Don't see any other questions or comments. I want to thank the members of this panel. You provided us a lot of things to think about and some follow-up questions as well. We're now going to move to a break. We will now be on break until 10:30 a.m. Eastern Time, and we'll come back with saluting global immunization efforts, 154+ million lives saved. Thank you for joining us for June 13th, 14th NVAC meeting.
Produced by the U.S. Department of Health and Human Services.